Welcome, everybody. In honor of Native American and World Indigenous people, we have the pleasure of hosting three remarkable individuals. They gather to share their perspectives on challenges and successes they have experienced, as well as their thoughts about what lies ahead. So joining us is Htoo, a Karen English CoreCHI certified healthcare interpreter who was born in Burma and fled to Thailand to seek refuge from the Burmese military. Pla currently resides in the Minneapolis-St. Paul area and works for M Health Fairview, representing both the social services healthcare system and the Karen ethnic community. Joining us as well is Maggie Herrera. She is a Navajo English medical interpreter and one of the Spring 2021 CoreCHI scholarship recipients. She was born and raised on the Navajo reservation where Navajo, Dene, was her first language. Maggie has been working in healthcare for over 16 years. She currently resides in Albuquerque, New Mexico, and is very proud to be the voice for her people, Dene. And last but far from least, joining us today is Victor Sosa, a licensed interpreter trainer and co-author of the Indigenous Interpreter. His interpreter career has spanned more than 2 decades, having worked as both a Spanish-English certified court interpreter and certified healthcare interpreter. Victor's passion for the Indigenous interpreter experience has permeated his life's work, and presently, he is the Interpreter Services Manager at Natividad Hospital, a public safety net hospital along California's Central Coast, and he works with the Indigenous immigrant population in his area. I would also like to take a moment to thank today's ASL interpreter, Rita, and a Language Line Solution sponsorship, without which this roundtable would not be accessible to ASL communities. And now, without further ado, Victor, please take it away.
Oh, thank you very much, Zoe. We're such a privilege for all of us to participate, and we come from very different places. And I was telling Maggie and Plateau, I wish I could just listen to their experiences because I don't know much about the Navajo and the Karen. So I think it's going to be very enriching for us also as individuals. And just to get started, I'd like to give Maggie the opportunity to maybe tell us a little bit about her work with the Navajo, maybe a little bit about her community and how her experience has been working with the Navajo.
Yat anotko she Maggie Herrera yinshia. Tena habitli shlon na kaidene bashichin. Kachini dashichi hashk antohi dashanala. Ahot is sananshle. Dot usage ashikedo balaganas nas holedo auto ashike do aheha. Hello everyone, my name is Maggie Herrera. I am a Sleep Rock born for Mexican clan. My paternal grandfather's clan is Red Running into the Water. My paternal grandfather's clan is Yucca Fruit Strung Out. It is a pleasure to be here and thank you for having me. A little bit about myself, and like I said, I was born and raised on the Navajo reservation. The Navajo is like the biggest tribe in the United States, and it kind of expands through the four corners. The four corners, which entails the Utah, Colorado, New Mexico, Arizona, where the states meet together. That's where the Navajo reservation expands. And, the community out there, there's really a lot of lack of resources in so many ways. One is the education. A lot of the elderlies that we have they don't understand English nor speak the English. So, and with my experience of being part of the healthcare, I've come to find that a lot of my people don't understand their diagnosis or their trouble that they come to the hospital for. And that's where I stepped in to be their voice, to be that bridge, And if they have questions to ask, I'm there. That, it's good to see that they find what's their problem, what is wrong with them. So a lot of it's the Navajo speaking that is not being the English. It's the Navajo language itself is very descriptive and it's very sensitive at times. So that's what I come to find out. Thank you.
I'm kind of curious, Maggie. You mentioned those states. Do you have to travel a lot to assist, or do you only stay in the reservation where you live?
Well, actually, I'm residing in Albuquerque right now, and we have the hospitals here. So a lot of the patients are coming in because Albuquerque is where they have the big city, the hospital. So a lot of them are being sent to Albuquerque for healthcare, and that's where I come in. I meet them, and a lot of the elderlies, they're not familiar with the city life, a lot of the technologies, a lot of things that are around their surroundings, they're not familiar with it. So they come to the hospitals a lot, and that's where I step in.
Thank you. We're getting to know a little bit about your work there. What about you, Plateau? What could you tell us about your experience?
Thank you, Victor. Halave Kogade, Yimime Plateau. Good afternoon, everyone. My name is Plateau. On behalf of Fairview, I'd like to thank CCHI for having conversation with you fine people. I'd like to tell you a little bit about Karen people, spelled as Karen. Karen is one of the indigenous people that have lived in Burma. We live in harmony. We're just a simple people farming until the Burmese and other ethnics came in, and the Burmese military come up with their own military power and push us away to mountainside. We still live in peace, but they still come with the military power. Some hide in the jungle. Many, like myself, we fled to Thailand, seek refuge. I lived in Thailand for about 10 years, and in 2008, I came to United States. In here, our Karen community is the largest throughout the whole United States here in Twin Cities area. The most common challenge I see in my community is difficulty in finding resources, what's available out there for my community here.
Mm-hmm. And Plateau, you speak really good English. Wow.
Thank you.
Where did you learn it? If you were in Burma and then you went to, you didn't come directly here, right?
No, I was born in Burma, then came to Thailand, seek refuge there. I came here with non-English, but with good education system here. I get to attend to school, learn English. I've been translating for my friends and parents, but I've never known that there'll be interpreter job as a career to do here until I came to Minnesota and I realized that there's a job that we can help our community, especially in healthcare here.
Yeah, what a beautiful experience. Like many, you start doing the interpreting, you didn't even know that was the role, and eventually you walk into it as a profession, and that's a beautiful experience. Well, the past 10 years, I've had the opportunity to help the indigenous immigrants from southern Mexico, and many of them have migrated here to the central coast of California because we have a huge agriculture industry. As a matter of fact, Salinas, where our hospital is located, is considered the salad bowl of the country. So next time you're eating a nice, beautiful salad or some strawberries, more than likely, you look at the package, it says Salinas, and many of them work here in the fields. And of course, not only do they not speak English, but many don't even speak Spanish, right? There's 11 language families in Mexico, native language families, and 68 languages. But something interesting about the languages in Mexico is that they have, from those 68 languages, there's 364 variants. So one difficulty that many providers have is that they can identify the language, but sometimes they don't know the variant. So somebody might say, well, they speak Mixteco, but Mixteco has over 80 variants. So it's not enough to know that they speak Mixteco. We might get somebody with a different variant and they still can't communicate. So that's, one of the challenges that I experienced when I arrived here over 10 years ago. And we started to try to provide more access to healthcare and to services for the farm workers and the mainly the indigenous immigrants from Mexico. Another thing that happened was that for many of them, their perspective or how they see health is very different than Western countries, right? Their thinking of health is like the whole body. They seek cures from maybe natural forms of healing. But here, the westernized countries, it's all symptomatic. Tell me what's hurts, and then we go from there. And so sometimes that has been a difficult to bridge the gap between the languages, right? Because of what they're thinking. An example I have of that is one time a patient came in and she was going to have a baby, but she hadn't gone to any prenatal care. And the nurses, they were shocked. They said, oh, we can't believe you didn't go to prenatal care, and that's not responsible. And they kept talking and talking. And the patient said, oh, I didn't know having a baby was a medical condition. And they just stopped and thought, well, that's true. It's not a medical condition. It's a really natural process. And, so it's both sides have had to kind of adjust their thinking to be able to provide the best experience for patients. And I don't know, you probably have similar experiences, I'm guessing. Is that right, Maggie?
Yep.
Or Htoo?
Yes.
Yes, that is true.
And what challenges have you experienced by helping as interpreters, things that I know Htoo mentioned resources. That's another big one, because many hospitals want to provide an interpreter, want to provide access, but sometimes they can't find an interpreter.
Sure.
Have you seen any other challenges?
Yeah, I've seen so many challenges, and one is the interpreter for Navajo. And also, like what was mentioned before, is the resources. For example, coming from the reservation, a lot of these patients, the elderly patients, the non-English speaking, they come from the rural area to where there's some they don't have, like in their living situation, they don't have electricity, they don't have running water, and they don't have telephone. So a lot of the difficult probably would be making an appointment for doctor's follow-ups, or lack of transportation and lack of clean water, all of that. Now that the winter is coming at this time, and there's a lot of wood stove, people are needing wood. So, and patients that come here to Albuquerque getting discharged, they're told, with an interpreter present, you need to do this, do that. But when they get home, do they have all the resources? The majority, they don't. And they can't call to make an appointment. So those are a lot of the difficulty that that's been challenging.
That's so insightful, because providers sometimes assume that they have all those resources, right? They think, well, everybody has electricity, everybody has telephones, and then they assume that, and you go back home, you're discharged, but you can't do the things they told you. That's so insightful. Htoo?
There's several challenges that we face in our community as well, but one common challenge that I've seen most of the time is anxiety and depression, especially our elders. living back in the country, back in Thailand or Burma. We live in tropical rainforest. We farm. We are active. Most of the time, occupy ourselves. But come here, we encounter new cultures. It's for our young people. We go to school. We see friends. It's easily for us young people to adapt to it. But for the elder people, it's hard. Most of the time, they'll just sit at home. They have nothing to do and feeling lonely, depressed at home. Back in the country, we don't know what's depression is. It's a diagnosis that we don't know until we come here. They realize that they have those symptoms. They can only heal with effective therapists. That's when us interpreter come in and help them throughout their journey here.
Yeah. Wow. I would have never thought about that. Now, one other thing, and I don't know if this happens also in Karen and Navajo, but sometimes there are no equivalencies from like English or Westernized concepts to like native languages. And so there's no equivalency. So
yeah.
I remember one time I was helping a doctor and we told the Mixteco interpreter the diagnosis is cancer. And the Mixteco interpreter said, well, you know, I could say it in Spanish, but we have no word in Mixteco. And the idea doesn't really mean anything, right? But, you know, us in English, we hear the word cancer and it scares us, right? Because we know it's serious. But that wasn't going to be the case with the patient because they were like, I don't know, I never heard of that before. So that's something that, you know, professional interpreters interpret into native languages, they struggle a lot with that because, you know, there's no real way to say it. And sometimes the more complex the problem is, the bigger the gap is. Do you guys have that like in your languages too?
Yes.
Go ahead, Plato.
Terminology is one of the most common challenge that us Karen interpreter face. I remember throughout my career, I've encountered many terminology that I don't understand. And again, as interpreter, the expectation is high. In medical field, there are various specialists that we have to understand, but we don't know all of them. And there are times when a term that can't interpret word to word in our language. In that case, we'll have to ask for clarification. So me and my friends, we try to come together, figure out how do we find those missing pieces, make it better for interpretation.
That's a great point. And any interpreter for native languages that just heard that is important because a lot of times interpreters think that they're on their own and they have to figure it out themselves.
Yes.
But when they do something like you, Plateau, where you guys have like a round table, you talk about it, you say, well, how do you do? Then it enriches everybody there and the language. That's awesome. What about you, Maggie?
Yeah, it is like with the Navajo, there's being that Diné Bizad is really a descriptive language. So there are certain things that there's no words for it, really, like you said. And it being that it's descriptive, if you were to interpret word for word, it would not make any sense. So a lot of times I run into doctors, I said, I didn't say all that word. I thought I just said 3 words. So here I am going on, being that it's very descriptive. So a lot of them, like you do a lot of clarifications, and also being that so sensitive. The Navajo people, we don't really talk about the death. That's one thing that we don't really talk about it, and especially if they're in the hospital. And then when it comes to code status, that would be one of the challenging, and how to approach an elderly. Some might cut you off. I don't want to hear it. You know, some might just listen, hear you out. So you kind of have to go around and get to a point. So it is a challenging. That's the more challenging for me at times.
Yeah, and that point about death is the same thing with many of the native peoples of Mexico, you know, because if you talk about death, you bring it on quicker. But then here in Western countries, they said, well, we have to have a palliative care consult to know, and they want to talk about death, and the patient says, no, I don't want to talk about that, you know, and the interpreter is there in the middle trying to figure it out. One thing I was going to say is sometimes the interpreters get, like the native language interpreters get challenged because, you know, Plateau say, well, we have to clarify. But what if everything is out of context and you're constantly clarifying and clarifying and clarifying? Then the provider says, well, what's going on, right? So sometimes even the standards that we use in healthcare, you know, we have to kind of stretch them, because if you don't, you know, they don't always work as efficiently with native languages. Another example is like first person. I don't know about your languages, but many of the native patients don't understand first person, right? And so some of the interpreters have to the provider, they speak in first person, and to the patient, they speak in third person. And you might say, well, that's kind of like a violation of the standards, but if you don't do that, the patient gets confused, right? He looks at Plateau and says, what? You're going to give me the injection, but you're not the doctor. Yeah. I don't know if that happens in your cases.
Yeah, I can relate it to that, Victor. Yeah, some patient, well, before the appointment start, we did introduce ourselves, say to the patient that we'll interpret as first person. Some patient did understood, but some didn't. So in that case, we let the provider know that we'll interpret as third person for the patient and provider effective communication.
Oh, that's a great suggestion. You were going to say something, Maggie?
Yes, a lot of them in the Nebizat, the interpretation in the Navajo, it's a lot of them is 3%, because a lot of them, if it comes to very sensitive subject, then you kind of like, this is what happens when someone, you know, like if this was to happen to somebody, this is what has happened. You know what I mean? Like you kind of have to put everything on someone else. This person went through this and this is what happened. Mm-hmm. So you kind of have to put it, and then especially the sensitive subject, you kind of have to go back and forth with the provider as well. So it's challenging at times, yes.
Very insightful. You know, and sometimes you as the interpreter are the only one that sees it, right? And well, right now we get to share it with others. You know, we could go on for another hour, but one thing I thought maybe, I don't know if you had something in closing you wanted to say. One thing I did want to say in closing is that from my perspective, one of the hardest things that we have is to recruit more Indigenous or native speakers to become interpreters. And a lot of times it's not because they're not available or they don't want to, but there is no pipeline or, you know, a road to be able to get there. And we have worked hard for the last 10 years to try and create that, so that individuals that speak a native language and from Mexico, and they speak Spanish and English, you know, they can develop personally and get into the space of being a professional interpreter. So some of the original people we trained back in 2011 are now mentoring those that are coming up. And we've had kids right out of high school, you know, walk into the profession and get training, and you know, they're really doing well. You know, I would say about half of our interpreter staff now speaks a native language from Mexico, and you know, we're really proud of that. But wanted to kind of say that in closing. I don't know if you two had something you wanted to share about interpreters or your experience, something you wanted to say in closing.
Yes, Victor. Here in mHealth Fairview, we are looking for more current interpreter as well. But in order to become interpreter, of course, you have to go through training and classes. Really need interpreters, but a good one with experiences and fluent in both languages.
Do you guys offer any like assistance for somebody that may speak Karen, and some English, but they just don't know how to look for training or.
Yeah, there is an organization here, KOM, Korean Organization of Minnesota. They're an organization that help people who wants to become a Korean interpreter, taking their 40 hours training and develop from there.
Nice. What about you, Maggie? What can you tell us?
This is with my experience and the years that I've interpreted, I've really, really enjoyed it. You know, it just brings a sense of communicating with our people, and it would be very, very nice to have Navajo interpreter more to help out. I mean, the Navajo Nation is so large, the biggest tribe in the United States, and having interpreter at all healthcare facility would be wonderful. A lot of our people would get their questions answered, their diagnosis figured out, and there's so many of them are just, like they say, fall through the crack, and now they're more sick, they come back. And it's been a rewarding and challenging at times for me, but you know, knowing that when I know that I'm the bridge and the voice for the patient to the provider, and seeing on the patient's face that they understood their diagnosis, they figure out what's going on, now they're going to do this. That's a really good feeling, and thank you.
Yeah, that's really satisfying to see that your little contribution helped in making that experience better. And you know, I the same, Maggie, I share the same feelings. It's so satisfying to me to help. I mean, I love people in general, but those that are in more need and those that are more vulnerable, it's so satisfying to say, you know, I was able to do something to help, even a small contribution. So thank you. I completely share your feelings. Well, thank you.
Thank you, Victor.
Well, number one, thank you to you three individuals and our ASL interpreter as well, Elita, for being here, for giving us the gift of your time and your thoughts about your experiences, your challenges, and it feels like between the lines, your successes as well. So I want to thank you all for joining us today for this roundtable conversation.